video off?
Yes, please. Good evening, ladies and gentlemen. We're just going to start in about 30 seconds from now, allowing people to come in from the waiting room. Thank you. Hey, Dr. Hussam, floor is yours.
Walid, shall we start?
Yeah, the floor is yours. Go ahead. Go ahead, yes.
Okay. So good evening, everyone. My name is Hussam Magdi, and I'm working as a medical science liaison at Novo Nordisk UAE. So firstly, I would like to welcome you all to today's webinar and Dubai Pediatric Club meeting, where we are going to discuss the management of growth disorders. Today, we have experts in the field of pediatric endocrinology, Dr. Hana Zidan and Dr. Nando Salanji from Dubai, and we have our chairperson, Dr. Sohrab from NMC Hospital. So I would like just to introduce Dr. Sohrab. Dr. Sohrab is a senior specialist pediatrician at NMC Specialty Hospital in Dubai, and he is the president of the Dubai Pediatric Club meeting. And he is going to present a small presentation about the history of growth hormone in pediatrics. And before starting Dr. Sohrab's presentation, I would like just to tell you some housekeeping notes. You are joined in the mute. And in case you would like to ask questions, you are encouraged to write your questions in the Q&A section. And at the end of the webinar, we are going to have a survey. So please try to respond to the survey. So now, Dr. Sohrab, the floor is yours.
Thank you very much, Dr. Magdi.
Thank you.
I'd like to good evening, ladies and gentlemen. On behalf of my colleagues in Dubai Pediatric Club and organizing committee of the Dubai Pediatric Club, I would like to welcome all viewers from Dubai, UAE, and all other countries to this webinar. This webinar is organized and hosted by Novo Nordisk company. I would like to thank the country manager, Dr. Rakesh Nair, Dr. Hussam Magdi, and Dr. Sharif Hamdi. Well, I would like to bring into notice of the viewers that pioneers in the field of endocrinology and pediatric endocrinology established this company. Later on in one slide, I will share with you about this company. This is my disclosure. Well, I would like to welcome all viewers, those who have not seen Dubai, to come to this beautiful city. This is a view of beautiful Sheikh Zayed Road, one of the best beautiful roads in the world, with the background Burj Khalifa, the tallest building in the world. Well, these are the members of Dubai Pediatric Club. On behalf of all of them also, I would like to welcome you all. The executive committee of the Dubai Pediatric Club, Dr. Joshi, Dr. Kalpana, Dr. Ayman Jundi, Dr. Amir Tolaimat, Dr. Diari, Dr. Rafi Awara, Dr. Bandari, Dr. Bushra Azam. She'll be joining us in question and answer. She's senior specialist pediatrician from Prime Hospital, and Dr. Khalid Rashid. Well, just to bring into your attention our annual, 6th annual Dubai Pediatric Club conference, which will be held on 28th November 2020 at Maroj Rotana Hotel. It will be both at the hotel and as a webinar for all over the world. Save the day. We have two eminent speakers, two eminent pediatric endocrinologists, well known in UAE, Dr. Hana Zaidan and Dr. Nando. In a short while, I'll be introducing to you. Well, briefly, I would like to discuss with you the history of growth hormone and its use in pediatric with a brief history of pediatric endocrinology. I always start my talk with the name of Hippocrates, the father of medicine. Everything, as I have said, starts with Hippocrates and end with Hippocrates in medicine. Well, today's talk is on pediatric endocrinology. These three, you see, they are pioneers of pediatric endocrinology. On my left, you see, this is Dr. Arnold Hagfeld. He is a German physiologist who worked on hormones, and he is one of the pioneers in the field of endocrinology. The person who is in the middle, all of you know Thomas Addison. He is from Guy's Hospital. His name is associated with Addison disease. He is considered as the father of endocrinology. And on my right side, I like to request me to bring the photo down because I can't see my screen. So on the right side is Charles Edward Brown-Scott. This is controversial pioneer and father of endocrinology. It has been mentioned in literature. He is well known for his Brown-Sequard syndrome, partial damage to the spinal cord with hemiplegia and the other side, condylators sensory loss. He has been mentioned in the endocrinology also. Well, Lawson Wilkins is considered as father of endocrinology. I would like to request all the pediatricians, those who not know, he is considered as a father of pediatric endocrinology. In the spring of 1950, Dr. Lawson Wilkins made a presentation at the 6th International Congress of Pediatrics in Zurich that gave birth to the new field of pediatric endocrinology. In the center, you see Dr. Megan, the student of Dr. Wilkins. If you see on the right, he has kept the picture of his teacher, Dr. Wilkins. Well, I tried to find out the portrait of my teacher to keep in my room. I didn't find any. I kept my own portrait here. Well, this is a beautiful picture. On my right is a Harriet Lane home. As you see, this is an Harriet Lane home for invalid children. I would like to bring into the attention of the viewers that Harriet Lane home was the first pediatric endocrine clinic established there. The chief of that was Dr. Lawson Wilkins. He established the first pediatric endocrine clinic there, and this clinic was taking care of children with growth failure. The talk of today, see how important it is. On his right is Dr. Megan, and on his left is Dr. Blizzard. I will talk about that. Very interestingly, see, all of us, we are having Harriet Lane book with us, and Harriet Lane, briefly I'll tell you about this Harriet Lane clinic and home. It was established in 1912. Actually, there was a lady called Harriet Lane Johnstone. She was the niece of President of America, James Buchanan, and First Lady of the White House. She, in 1903, before her death, gave $400,000 in 1903. See, in that time, he donated this much money to make a Harriet Lane home for invalid children. And this was carried on, and in actually it started 1903, then 1906. The first pediatric chief and professor there was Pirquet. Pirquet is the father of allergy in pediatrics. He was followed by John Howland. John Howland is a pioneer and considered one of the fathers of American pediatrics. And Dr. Lawson Wilkins won an award in his name. This was just a brief history. Here you are seeing on the left Dr. Megan and Dr. Blizzard in front of the Harriet Lane home. They are the pioneers of that. I would like to mention here that after Dr. Wilkins died, Dr. Blizzard followed the pediatric endocrinology as a professor of pediatric endocrinology, And Dr. Megan was the president of Pediatric Endocrine Society, which many pediatric endocrinologists are member of that. They are the pioneers. We must know their names. And this is a picture, Dr. Nando knows about this. This girl you see, she was called Lois. At her first birthday, this shown with Dr. Gardner and Dr. Lawson-Wilking. Lois was the first baby with the south-losing form of congenital adrenal hyperplasia who survived with treatment of cortisone, south-losing hormone, in 1951. I want to mention here that Dr. Megan also was one of the pioneers who treated for the first time by using cortisone this type of patients. Here you see Dr. Megan with the very first non-south losing the patient with portrait of Dr. Wilkins. But this is a beautiful picture, 1954. A dinner was organized to honor Dr. Wilkins. You see Dr. Wilkins here with his wife, and here is Dr. Megan and other fellows of pediatric endocrinology. Very nice picture. This picture, this is very interesting. This picture is taken few months before death of Dr. Wilkins. Here, Dr. Wilkins, he himself invited all his fellows trainees to come and have a function. I think he knew he's going to die. You see here, standing here is Dr. Megan, here is Dr. Belisard, and all other famous fellows of the pediatric endocrinology. Very nice photo. Here, I would like to mention about growth hormone, the pioneers of the growth hormone. On my right, you see Dr. Lee and Dr. Maurice Robin. Both Dr. Lee and Robin separately discovered and isolated growth hormone. And on left, you see Dr. Robert Belisard. He used growth hormone for the first time for the children to increase the height. Well, in brief, I mentioned that growth hormone, the first time was isolated in 1951 by Dr. Liam Papkov in California and Dr. Robin in Massachusetts. Of course, the biochemical structure was known later in 72. In 1981, the first recombinant human growth hormone was developed by Genentech. And this I want to mention, till 1985, they used cadaveric form of growth hormone, which caused in 4 patients, Creutzfeldt-Jakob syndrome. I'll mention about that. And this made FDA to make the recombinant growth hormone. Well, as I mentioned, in 1985, obtained from the extraction, and but treatment with recombinant growth hormone does increase adult height. That is why growth hormone treatment of growth hormone deficient adult was approved by FDA in 1996. Well, here you see Dr. Lee in clinic. Now, interesting about Dr. Lee. Dr. Lee, the endocrinologist who discovered the growth hormone when he was in Berkeley, San Francisco. Well, one of his other achievements are beta endorphins, one of the most powerful painkillers. But his achievement is because of the discovery of growth hormone in 1955, and which was this approved in October 1985. Dr. Lee was born in China. He came to the United States for a study. It is interesting to know he became the US citizen in 1955, just after discovering the growth hormone. So if you want to be the citizen of the United States, you have to discover some hormone. Well, this is Dr. Belisard. Dr. Belisard was the first to use growth hormone to boost children's height. He said, I may not be as tall as Robert Wadlow. Robert Wadlow is the tallest man in the history, where 8 feet, 11 inches and 1 centimeter, the tallest man in the world. Dr. Belisard said, I have increased the length of American by 11 miles by using growth hormone. Well, this is Dr. Maurice Robin, the other pioneer which used growth hormone in a boy. Well, these are the milestones in the development of the growth hormone. You see, from 1912 till today, Only in 1985, because of, before this, the cadaveric growth hormone was used and they found Creutzfeldt-Jakob disease. So FDA approved the license of recombinant growth hormone. And these are the conditions FDA approved the uses of growth hormone. And on the right side, you see the year. It started with the childhood growth hormone deficiency in 85, chronic renal failure 93, HIV, wasting, adult growth hormone deficiency 97, Turner syndrome, Prader-Willi syndrome, short children born small for gestational age. This Dr. Lando will discuss in detail regarding these things, hot topic, idiopathic short stature, then short bowel syndrome, going to Noonan syndrome. Well, newer generation of growth hormone came in 1971. Nanormone was produced. The recent generation, Norditropin, was approved in 1991, which is now used in almost 80 countries. I would like to mention here, this is good news. Just a few days back, FDA approved the first once weekly growth hormone in adult. That is somapacitin, marketed at Sogroya. This is the latest, few days, just a few days back it was announced. Now, I would like to mention, this was very interesting for me also. Initially, I mentioned about Novo Nordisk. I would like to bring into attention of the viewer that this company was made by pioneers in the field of endocrinology. On the right, you see Banting and Best. Insulin was discovered on 18 July 1921 in Toronto University, Canada, by Banting and Best. Of course, there were 4 of them. You see here, Banting, Best, Dr. McLeod, and one of his colleagues, Dr. Colib. Now, Dr. McLeod was the chief of them. Under his directorship, this process was done. And I'll mention about interesting fact about that. Now here, this gentleman you see here is August and Mary Kroc, their husband and wife. August won Nobel Prize in Physiology in 1922. They were invited to the United States to come and give talk there. They went there in 1922. His wife was a diabetic patient, diabetic type 2, and he was seeing lots of patients with type 1 diabetes. His wife noticed there that many patients are treated with insulin. Then asked her husband to contact the Toronto University, Dr. McLeod, and ask him to allow them to produce this in Europe, Northern Europe. Actually, in Denmark, Copenhagen, they established. Now, I want to tell the viewers why Nordic. Nordics come from Nordic, means countries of Scandinavian region in the north of Europe. So that is why this is called Nordic. Now, August approached a person called Hans Christian Hagedorn. I would like to mention about he is one of the pioneers of pediatric endocrinology. Since our MBBS days, we remember insulin MPH, insulin MPH. What is MPH? Actually, in 1936, this Dr. Hagedorn, he discovered protamine. And later on in 40s, he incorporated to insulin to make NPH insulin or neutral protamine Hagedorn. This is actually, he is a pioneer and he has established his company. Now, these two, they wanted to establish company, but they didn't have money. They approached Dr. August, who was pharmacist, and he was very rich. He also agreed, so they made a company. They named that company Nordic Insulin Laboratory. Now, there was 2 brothers, one Harald and Torvald Pedersen. They joined also this company. The Harald was in machinery and the other one pharmacist. But after 2 years, they had argument with Dr. Hagedorn, and they left and they made a company called Nova. Nova comes from the Latin word new, innovative. They started also producing insulin, so they became rival. In fact, these 2 brothers, they produce insulin syringe. So They were competing with each other. After 65 years, in 1989, they joined together and they formed a company called Novo Nordisk. This is the history of this company. Now, about this insulin, in 1923, Nobel Prize was given to Dr. Banting and McLeod. They ignored Best and Colib. At the ceremony, Dr. Banting got very angry. He said Best was also there. Why he has not received? He split his award with Best. When Dr. McLeod saw it is like this, he was, feeling very bad. He said, I will split my award also with Colib. It is very interesting to know that Banting and Best, they did not make insulin patent. They said we want all patients throughout the world, they benefit from that. They receive only $1. Remember, $1 as a compensation for discovering this insulin. This was the history of this, and this was the history of the how from 1922 till today it went. And this is the old age of these pioneers in that. It produced havoc in the newspaper. This was the diabetes. This was the history of that. Now, today we have two great eminent pediatric endocrinologists. I think in future they will get Nobel Prize in pediatric endocrinology. On my left, Dr. Hannah Zeidan, consultant pediatric endocrinologist, American Hospital. On my right, Dr. Nando Talenge, the consultant pediatric endocrinologist at Al Jalila Children's Hospital. Briefly, everybody knows about them. I'll introduce them. Well, Dr. Hannah Zeidan is the MD in the pediatric endocrinologist at American Hospital, Dubai. She's American board certified in pediatric and pediatric endocrinologist. Dr. Zeidan graduated from Faculty of the Medicine from Jordan University, Amman in 1998. She did a pediatric residency at Lincoln Medical and Mental Health Institute in New York, USA in 2005. Dr. Zeidan did 1 year of pediatric chief residency at Mount Sinai Hospital, Chicago, Illinois in 2006. And Dr. Hannah did also a pediatric endocrinology fellowship at Medical College of Wisconsin, Milwaukee, USA, 2009. She worked as a pediatric endocrinologist at the Children's Hospital from 2009 to 2014. Then she joined the American Hospital, Dubai, from 2019 till today. She is there. Dr. Zeidan is a fellow of American Academy of Pediatric Endocrine Society and Pediatric Endocrine Society. This is a Pediatric Endocrine Society which I said from the time of Dr. Wilkins, Dr. Megan, all her research interests are vitamin D, and obesity, and pre-atherosclerosis in children with type 1 diabetes. Briefly, our next speaker is Dr. Nando. Actually, Dr. Nando got his MD in Manchester. He was there for a long time. And after long practice in Europe, he came to Dubai in August 2017 to establish the diabetic endocrinology unit and the weight management services at Al Jalila Hospital. He has over 30 years of experience as a clinical endocrinologist. Dr. Nando now leads a strong multidisciplinary diabetic team at Jalila Hospital, which involves nursing, the dietetic, and psychology colleagues. The service embraces the technology with all the patients using glucose sensor, and many of them are on, almost all of them are on the insulin pump. In the growth field, he introduced the arginine test, a cost-effective, safe method, test for growth hormone deficiency, and brought a bone expert method for estimation of the bone age. He has done a lot of work in weight management. He introduced the use of body composition for the diagnosis and management of this challenging group. Additionally, this is important, Dr. Nando has a significant interest in education and he teaches to a wide range of the audience, and I was appointed as adjunct professor of pediatrics at His Highness Sheikh Mohammed bin Rashid University in April 2019. But with this, as I said, everything starts with Hippocrates and ends with Hippocrates. Just a few quotations that I'll mention, one of them. Hippocrates says some patients recover because they believe in doctor. This is really true. And of course, he said, it is more important to know what sort of person has a disease than to know what sort of disease a person has. He has a book on quotations, but with this, I end. This is a beautiful view of Dubai with Burj Al Arab, the first 7-star hotel, and on the background, the tallest building in the world, Burj Khalifa. I would like to invite those who have not seen Dubai to come and see this most beautiful, safest, cleanest, and best city in the world. Well, with this, I end, and I would like to request Dr. Hannah to start her talk. I would like to request all viewers to write the question and answer box, and avoid writing in the chat box. And at the end of this presentation, there will be a questionnaire which we request you to fill. Thank you very much. Now over to Dr. Hannah. Dr. Hannah, please. The mic is yours.
Thank you, Dr. Sohrab. Welcome, everyone. I would like to thank also Novo Nordisk for giving me this opportunity as well. And I would like to welcome all the attendees from all over the world. Hopefully my talk will be short and sweet. So as Dr. Sohrab nicely introduced me, I really currently work in Dubai, but I receive and see patients from all over the Middle East, GCC, Africa, Asia, and Europe as well. So, so at the beginning, I would like to, this is my disclosure. And I would, I mean, again, this is a topic that's dearest to my heart. Pretty much when we are running a pediatric endocrinology clinic, almost 75% of our patients are being assessed, especially for growth in some way or the other. So really, this is what we do on a daily basis. And I know in pediatrics in general, as pediatrician, 50 to 75% of the work you guys are doing on a daily basis is really assessing growth, because growth is a sign of good health. It's a fundamental characteristics of early childhood. It's kids usually grow in predictable manner. And it's very important to know what normal growth patterns and variation from that to really assess or appreciate abnormal growth. It is very important to monitor frequently, accurately growth in infants, very often in the first 1 to 2 years of life, and less often, or at least on a yearly, every 6 months basis later on. And this is very important clues for us as pediatric endocrinologists and pediatricians to help us manage those kids in general. And please not forget that as well as growth is also a condition that might affect other other systems in the body, and growth could be just a sign of growth failure could be just a sign, but it could be also a symptom of many other disorders in the body as well. And we'll talk about this a little bit more in details in the later slides. And I think this is one of the most important slides in my whole presentation. I started knowing this information as a medical student when I started my pediatric rotation. And at that time, really, it didn't matter what those numbers are. But as a pediatrician and a pediatric endocrinologist, this was really one of the important facts about growth and development early on. The first year, so on average, babies are born around 50 centimeters of length at birth. And the first year of life compromise so this is a graph represents growth velocity versus the age in months, then years. And as you see from this graph, It reaches almost 24, 25 centimeter. In the first year of life, we achieve 25 centimeter per year, which is on average, more or less for some kids or that, but on average or expected. So, and which is the fastest time of growth ever in our lives as human beings. Then that number goes down to almost half of that, to 12 and a half centimeter in the second year of life. Then that goes to 1/3 of that, around 8 centimeter between 2 and 3 years of age. Then that number goes down to smaller. Then growth velocity or growth rate slows down between 4 to 7 centimeter per year, depends on which growth percentile you are on the growth chart. If you've always been on the 5th percentile, a growth rate of 8 centimeter per year, which is the normal for a 95th percentile child, is abnormal for you, and vice versa. So it's important. So this is what channels are. So each kid of these, or those young children, start their own growth channel early on, and most of the time they have to keep that. Then this growth rate slows down down to around 10 years of age, and that's the second time where average puberty starts and growth acceleration starts to go up. And with the peak high velocity in girls achieved between 11 and 12 years of age. Then they slow down on their growth to finish their growth between 14 and 15 and finalize their growth by almost 16. So most of the growth spurt happens in girls very early, slower, smaller, compared to boys who start around average age of 12 years. And it takes them more time. They peak around 13 to 15 years of age. And that's their peak high velocity, which is compared to the girls. It's later, higher, and it takes more time for them to slow down. And then they slow down, and they finish their growth around 17, 18 years of age. So again, this is one of the commonest questions I get in my practice. When do girls stop growing? When do boys stop growing? I mean, it only, I mean, in the general at these ages, but usually it depends on so many factors. One of them, the puberty starts. So again, and when we look at the factors that determine our postnatal growth, one of the most important factors in that is pretty much parental height. So genetics in some way or the other. Prenatal growth has, and genetics has that contribution, but in postnatal growth, we have so many other multifactorial environment that affects us. So even if we are the siblings of the same family, still we have different types of within the same family. A lot of seasonal changes affects growth. So we grow slower in winter compared to summer. A lot of psychosocial effects, especially growth stunting, emotional deprivation. Physical activity has been, but I don't think it's that much, but it's not a major determinant, I would say. Socioeconomic, I mean, kids in affluence would grow a little bit more, kids in poverty, any chronic diseases that affects our growth. And one of the most common reasons of poor growth is nutrition. So even if you have the good genes and you're not eating or not getting the enough calories, you still can fail on your growth. So then comes is how we as pediatric endocrinologists looked at growth. At the younger age group, we look at length growth velocity, which is pretty much how kids track on their growth charts, weight gain, height gain, as well as his circumference, because it's very important for our neurodevelopmental status. Later on, head circumference becomes less important, as most of the head growth happens in the first few years of life. It's very important, and again, this is something I always have to reemphasize, is to accurately measure growth rates in kids. In my clinic, I call it the zigzag phenomena. The zigzag phenomena happens when kids at different times of visits, of years, of different setups, they measured in different ways, sometimes with shoes, sometimes with no shoes, sometimes with a small shoes, sometimes with the high shoes. So again, this is where the zigzag phenomena is, and we try to clear those measurements to reach the maximum or the best accurate measure. In the children's below 2 years, it's the best to measure them in length using a length board. Make sure that the head is resting against the headboard and the legs are straightened, and try to move any extra clothing, preferably even diapers sometimes, to measure the weight at the same time sometimes. Measure the length ideally to the nearest 0.1 and make 3 measures and take the average, but ideally, yes, but sometimes who has the time to do this? But we try to do this in our clinic as we are a growth clinic. In kids above 2 years, measuring the height should be using the stadiometer. Stadiometer should be a wall-mounted device, and the kids should be standing in front of this measuring device. Their feet should be flat with no shoes, and touching the tip of that, and make sure there's a perpendicular line going from the eyes to the surface that we're measuring, and make sure that they're erect, they're not soggy, they're not really bending themselves, and make sure that they don't have any extra hair styles that makes measurements forcefully higher or lower, as well as, again, it's very important to monitor growth by a trained personnel. And I know sometimes you change. Sometimes it's very important to try your staff to measure the height, because changing those staff might change those measurements, and ideally in triplicate and take the average as well. A nice or a very important concept in height and in statistics is standard deviation. And this is a way for us to tell us and you how far this kid from his average height for his ethnicity, sex, and ethnicity as well. And I think some of the questions I received earlier on about what's the best growth chart. And this is actually what is represented in the growth charts. No matter what growth charts we're using, we still have to compare kids to so many other factors in addition to their ethnicity. And again, short stature at any height below -2 standard deviation, which is the 3rd percentile. So any kid who's below the 3rd percentile, and that's debatable. So what's 3rd percentile for this chart versus that, for that ethnicity, that's a question open for debate. But again, the lower, any kid who's below the 3rd percentile needs really an investigation. And again, it's very important, and this is another one of the common questions I got initially, is yes, we need to monitor growth on every visit. And especially depends on where you practice. There are some healthcare systems that kids are not seen on a regular basis. And sick visits are the only place where kids are being seen and monitored. And I've seen kids with hypothyroidism who grew for no 2 to 3 years because they their height were not checked. And all of a sudden the parents just realize that the kid hasn't grown in 2 to 3 years. So really, it's very important to try to capture the growth patterns to kids as often as available these kids are to our clinics. Sometimes I get kids with no other previous growth heights, and I have to make that prediction about the height as well. And again, when we measure those kids on the growth charts, we make sure that we account for prematurity and correct for that. And again, we're trying to compare this kid with their peers, with their sex, with their ethnicity, depending on the growth chart you're using. And again, we kind of predict where these kids are gonna progress on these growth charts, and they should maintain those growth charts. And these are what we call the percentiles. So normal height usually tends to be between 3rd and 97th percentile. And any heights above the 97 and below the 3rd is outside the normal distribution curve, but some of them might be still normal, but we still have to investigate them. It's very important also to look at the growth velocity, and minimum to assess growth velocity is to assess growth minimally, optimally, I would say 9 months, minimally 6 months, and preferably 1 year. But who has those kids comes exactly at the same birth date on a yearly basis. So even if you don't, even early on, if you start to fall off the chart, which means that your growth velocity has slowed down, we're able to pick up, if we start to calculate growth velocity early on, we're able to pick up those kids who fail off their growth charts early on before they cross those percentiles. And to calculate growth velocity, you just have to take the difference between the two heights, the times that elapsed, and prorated to how many per 20 months, because this is how we translate a growth velocity, how many centimeter per year. And again, this is what we tried our discussion with, is how many centimeter we are expected to go per year. So the question comes in, so what's the average growth rate for each kid? Again, if you are at the 50th percentile, you need to be growing around 5 to 6 centimeter per year to maintain that channel and not to slow down in growth. Then if you are the 5th percentile, then you need to maintain a growth rate of 4 to 5 centimeter per year. And if you are the 95th percentile, you need to maintain a growth rate of almost 7 to 8 centimeter per year. So really, if you are a 95th percentile child and a grow at 6 centimeter per year, you're gonna fall off the growth chart. So really, normal is normal for whom and what and when. So we always have to compare how the kid is growing the year before, if we have the information, and compare to that. And this is a very commonly asked questions in my clinic, how long and what's normal the growth velocity is. Head circumference also is very important, especially for kids in the first 2 years, especially to associate with brain development, which sometimes gives us a clue about growth failure as well. Height standard deviation is the concept also in statistics that has becoming more and more talked about in pediatric endocrinology, and most new articles and studies are comparing those kids and how much standard deviation score these kids are achieving. And this is a simple way to calculate the SDS. Mid-parental height is one of the very important measures when we look into growth. So we look at the kid, we compare him with his peers, his sex, and we look at the kids, we compare him with his previous growth. Then we look at the kids and we compare them to their parents' heights. And again, for boys, we take the father's height plus mother's height plus 13 centimeter and divide by that. For girls, we minus that. We expect most kids to lay within 10 centimeters from mid-parental height, target height. And if any kid that falls far below, above or below, then we have to really investigate. So short stature, how poor growth is defined. Short stature is comparing, we are comparing those kids to well-nourished, genetically relevant population, and ideally should be the population studies. So if you're dealing with kids, French kids, you have to compare them with French kids. And being practicing in Dubai, I have kids from all over the world. So mean height for a French kid is different than mean height for an American kid. But again, the question is, which growth chart should we use in Dubai or in other countries where you have so many population or mixed population? Again, I think you just have to use one and stick with it and try to add all these points together to make sure that you follow the guidelines. Then the question comes, what's the 3rd percentile for this or that population? And I think that's something we just have to maybe use a more international growth charts. Like sometimes I use the, some EMRs have the WHO, and in my clinic, I use the American. There is a very minimal discrepancy between both, but at the end, it doesn't make big difference in my decision making. If we apply the 3 rules of growth, absolute growth is important, but if we look at the growth velocity and mid-parental height altogether can be employed. At any time, height drops across 2 percentile, and that's what we've shown in the growth chart, and that's what we called falling of the growth chart. At any time, there's the growth deceleration, a growth velocity that's below the 5th percentile for age and gender, as well as a growth velocity below 1 standard deviation score, 25th percentile for age and sex, that is maintained for more than 2 to 3 years. So if you're not growing that fast, but you maintain this slow growth compared to your previous growth, then that is abnormal. And again, for preterm infants, we have to apply that based on their gestational age. So we cannot correct for absolute age. So, the criteria to initiate immediate investigation, any height more than 3 standard deviation, or any height more than 1.5 standard deviation below the mid-parenteral height, which is above 10 centimeter, roughly, of mid-parenteral height, or height more than 2 standard deviation below the mean, and decrease the height velocity. So we don't have to wait until the growth becomes -3. If the growth starts to slow down, in addition, the growth velocity is slowing down, and this is what caused the absolute height to go down, we can initiate a growth. And if you don't have any short stature, or the kid is still plots at the 25th, 50th, or 75th percentile, or even 95th percentile, but the growth velocity is below 2 standard deviation, what expected for their age and height, then we have to investigate. And I think that's something we can see easily in kids who develop brain tumors. They usually grow nicely at the highest percentile, then all of a sudden they start to slow down in their growth. To look at conditions, and again, when we investigate growth, we assess, we find, we diagnose growth failure, then we have to look or examine the etiology or the reasons for that. And I think when we look at the kids and we look at the growth measurements and we look proportionate is a good way to say, to see that. If you have a kid with frontal busting, if you have short limbs or abnormally very short, this is usually brings us to the disproportionate skeletal dysplasia, most likely. Sometimes kids are mildly affected and not severely affected, like in achondroplasia or hypochondroplasia. And sometimes we go to genetic testing forward and to find what are the other features that we need to look for. But again, with the explosion in genetics these days, sometimes it's very hard to diagnose the skeletal dysplasia based just on the features, and genetic testing can help us to do that. And then when we have a proportionate growth, normal genetic or familial short stature could lay into that. Constitutional delay of growth goes under that. Prenatal reasons, and I think Dr. Nandu is going to talk about UGR-SGA, are caused by any intrauterine infections, which has been documented or discussed prenatally or has been detected prenatally, as well as some genetic syndromes can affect your height starting at prenatal life. Postnatally, I think one of the most common causes of growth failures in general, I think, is malnutrition. Then comes chronic systemic diseases. Emotional deprivation plays a significant role, as well as endocrine disorders. So really, when we look at the endocrine, it's a diagnosis of exclusion of all other diseases, because if you look at the milieu, at the big one, it's not really the main reason for growth failure. But again, in pediatric endocrine clinic, it will be the main thing sometimes. Chronic systemic diseases, and I would like to point out to gastrointestinal especially, I pick up 1 or 2 celiac disease per month sometimes, and sometimes it's longer or less. Like in the last 2 weeks, I picked up 2 kids with celiac. And the very special about celiac in pediatric patients is it's very silent. The only signs and symptoms that can give us to poor or to celiac disease is just poor weight gain and height gain, and not just significantly poor weight or height gain, it's just mildly poor, which can pass like constitutional delay of growth of puberty or genetic short stature. A Crohn's disease can really affect your growth, but even with those group of Crohn's disease who have good remission, there are some genetic variability that makes some of those are even more prone to have short stature than others. So even if a Crohn's patient doing very well, we still have to monitor growth very well. And some of those kids we picked up in the pediatric endocrine, some that are referred to us by the pediatric gastroenterologist.
Anna, 5 minutes, please.
Of course, cystic fibrosis and short intestine is another reason. Other factors as well can contribute to that. The major, I would say the most common endocrine disorders that can contribute to pediatric endocrine disorders is hypothyroidism. I think that's one of the commonest we see in pediatrics. Growth hormone deficiency or insensitivity as well. Precocious puberty, as we have a splurge of a lot of cases of precocious puberty in the last 2 to 3 months, can initially advance your height, then eventually you end up at a shorter height than what you're expected. Pseudo hypoparathyroidism, that's the clue, is hypocalcemia sometimes. Inherited different causes of rickets, poorly controlled diabetes, as well as undiagnosed diabetes insipidus. Why it's important to diagnose growth failure and then refer to and investigate the causes. In a cross-section study in a pediatric endocrine clinic where they looked at 104 kids, GI diseases were one of chronic medical illnesses was one of the most highest frequency compared to the rest of the endocrine, non-endocrine normal variation of growth. So really, you pick up a secondary diagnosis in this clinic, and familial short stature was really a good chunk of that, as you see, because usual delay of growth was not that common compared to the contrary, especially as we know it's a common condition. It's typically in boys. And again, it's very important because the sooner you detect the abnormal growth pattern and you start the treatment, then you can really have a better effect at outcome or improving final health. This is the growth patterns of kids who are diagnosed early on at 2 to 5 years, 5 to 8 years, and 8 to 11. And the sooner you detect it, the better increase in SDS, standard deviation score for growth. And this is shown in growth hormone deficiency as well as small for gestational age. And it has been shown especially in girls with Turner syndrome. And I have diagnosed a lot of mosaic Turners in their late teens, 20s, 13s, and we lost the window of opportunity to correct their growth. And that has his own weight on in decreasing their predicted adult height and affecting their decreased bone density, because we usually delay the hormone replacement treatment and make their bone less dense at concurrent age for the same matched girls with non-Turner. And as well as if we miss the diagnosis, then we miss the guidance for them to help them with their learning problems as well as socialization because of their short stature as well as lack of secondary sexual characteristics.
Sorry, I'm interrupting. 3 minutes, please.
Yes, yes. So factors, so in a group of patients with Crohn's disease, the sooner the diagnosis was made from the onset of symptoms was associated with better improved height scores in adults. So the early we diagnose these kids, start them in growth hormone treatment, they have shown even almost 2.5 to 3 centimeter difference as adult height. Some people say, so what, 3 centimeters? Yes, but again, it's also the quality of life as well. If you know that you have the symptoms or you have this chronic disease, you feel more at risk and you would have started the treatment as well. Psychosocial impact of short stature, the jury is not out yet. I mean, we have reports that it affects, it makes you more, and there are some other reports says it's no, it's neutral, not effect. But I think and it's something very common we see often in our clinic, that kids being bullied for being short, they called names, it affects their social emotional status. Some kids just don't want to show up to school because of them perception that being short as well. And because of the late referral and the short failure later in life, this has been shown to might show lower academic attainment, lower income in Adelphi, and poor hand grip strength as well. So this is a nice, I would say, summary of what we just discussed for kids who are very short, no matter where you are. So I get those kids that was even -4 standard deviation. And again, we don't have to wait until the kids becomes really severe short stature. Early on, investigate, refer them to a pediatric endocrinologist. Let's start looking into different causes. At any time, we should refer them. Above 3 years of age, if you are very short, but your height SDS is less than -2.5, and you need to refer. But if you're only 2 SDS, then your SDS is more than -2, and if you have a short birth length, and this goes for the SGA, or you emotionally deprived, disproportionate features, if you have height below the target height range, please refer these to kids for further evaluation. And again, this is another summary to take off to diagnose what are the initial measurements, then what are the different conditions you look into, then you, based on these, what this comes, you refer to different subspecialties and or to the pediatric endocrinologist based on the pediatric endocrinology causes as well. In summary, growth is a fundamental characteristic of early childhood. Recognizing normal growth patterns and physiological variation is important to identify abnormal growth patterns. Early diagnosis and referral help identify causes and help improving final adult height. And with that, I conclude my presentation. I'll be happy to take any questions.
Thank you very much, Dr. Anna, for the excellent presentation. You covered almost many questions which are asked. Now I'd like to request Dr. Bushra and Dr. Nandu also to join us. Now, although you mentioned Dr. Pankaj Tagdeja, one of the senior specialist pediatrician from Al-Ain, a regular and sincere member of the Dubai Pediatric Club who attends all the meetings, he has asked this question, which is a question of everybody. You all mentioned, he has asked what growth chart to be used in the UAE with different nationalities. Is it wise to use the growth chart for Indian, growth chart for Indian, and CDC for others? And why the WHO growth chart is so difficult and cumbersome? With Dr. Nandu, both of you, you can discuss this question. Then I would like to later request Dr. Bushra to continue the questions, please.
Of course, ideally, we should use the growth chart of the certain ethnicity you're saying. So if you want to compare the kids to their matched age and sex within certain ethnicity, you prefer to use them for that. But remember is our kids don't go to the same ethnicity usually. I mean, in Dubai, they go to all the ethnicity. So sometimes that is, but that's still not the only factor usually in determining our, but again, no matter what ethnicity you are, you're still gonna continue or maintain a growth rate on this percentile or that percentile. So the other factors will also contribute to yours. So I would not say, don't worry about which actually growth chart, but preferably WHO or American growth chart. Remember, WHO has a multi-data from all over the world. And I think Dr. Asma, my colleague in Mafraq Hospital, is working within the Arab, the Middle East to work to develop special growth chart for each country. So that I think will give us more insight about what growth chart, and maybe you can modify it based on your patient, hopefully. But I think no matter what the growth charts we're using, we're still gonna be able to pick up those kids who fail to grow or far from their genetic potential as well.
Nandu,
so I agree with what Dr. Hannah says. Basically, you need to use the most appropriate growth chart for the child. So if at all possible, use the ethnically appropriate growth chart if you have one, but you usually don't. If you're dealing with a non-US child, I would say use WHO if you don't have a specific country growth chart. If you really are dealing with an American child, then the CDC is appropriate. There's not actually a huge difference between WHO and CDC, so you could potentially use either. But if at all possible, you should use ethnically appropriate growth charts. There are growth charts for UAE. I've tried to get the data for them. They were published in 2006, but unfortunately the authors are uncommunicative. So I haven't been able to get hold of that data. It was compiled on something like 17,000 children. So, you know, there is good data for Emirati children, but it's inaccessible. We only have graphs and not actual growth charts that we can plot in a clinically useful way. As to why the WHO charts are so badly designed, Goodness knows why. I mean, I think they were conceived by statisticians and not by people who actually work with children, unfortunately. So I hate them. It makes no sense to me. Why does the weight stop at 10 when the BMI goes on to 18? I mean, clearly they have the weight for those children because otherwise they couldn't calculate BMI. So it's nonsense. The idiots who designed them need to go back to school, I think. But unfortunately, we're stuck with what we have.
Thank you very much. Now I'd like to request you to give a short and brief answer. I'd like to request Dr. Bushra to ask the question. I have other questions also in the meantime. Dr. Bushra, please.
Good evening, everyone. Thank you very much, Dr. Hana. Really nice presentation, and I am sure we will also enjoy Dr. Nando's presentation. There is a question from Dr. Sharma, Davendra Kumar. In fact, two questions. How to calculate the target height in kids? And the other question is when should we worry about the small gestational age baby's length in clinic? So the second question, maybe we will leave for Dr. Nando's because I think he will present. And how to calculate the target height in kids? What do you think?
Right, so mid-parental height for boys, we add 13 centimeter plus parents' heights, then divide by 2. For girls, we minus 13 centimeters for girls, and we divide by 2. Dad's height, mother's height, plus 13 centimeters, all divided by 2. For girls, dad's height, mom's height, minus 13 centimeter, minus 2. And you plot.
At what age can we start using this?
Actually, for kids below 2 years, I do 2 growth charts. So I really plot the kid on the regular growth chart. Then I plot the 2 to 20 growth chart. So I really see where is his mid-parental height is and how he's far from his. I mean, if you're at the 5th percentile, you're not going to make the 75th percentile mid-parental height all of a sudden as an older child at 2 years. So really I usually plot that even at less than 2 years and see where the kid is still growing. But remember, kids change channels around 9 to 12 months and around 2 years, which is the normal variation acceptable. So some kids might just do more or less around that, but there should not be a big difference between where they are and where they should be.
Okay, there is one question, I think it was answered in the lecture, but no problem, we can repeat. Dr. Abdurrahman Isa, do environmental factors affect growth as well as genetics? So,
correct, yes. So in studies of identical twins who were raised in different environments, for sure that has happened. And we know that the new rising field in genetics is called epigenetics. So even if you have the same genes, the expression of some of those genes might be more prominent or less prominent, depends on the environment factors. Mm-hmm. So yes, of course. And it's in some environment, it's very obvious. And in some environments, it's not. So we looked at the data of Chinese kids who traveled from China to the US. Environment have gained them some height later on because of the change in the environment. And I think this is the most quoted quotation about the effect of in the environment. And again, if you have identical twins and you raise them in 2 different environments, you might see some difference in their height as well.
So I think this will answer the second question of Dr. Abdurrahman. Child who was born and living in UAE, is he different from home country? So I think this is the answer. Yes, it can be, right? If a child was born in the UAE.
Depends on your home country. If you have the same socioeconomic status to UAE, you would expect that the same, unless there are some very local factors affect growth there versus here. But if you have a good nutrition, good follow-up, good care, and not over-nutrition, I would say, then you would expect them to really respond to those genetic bases equally in some way or the other.
A very nice example of the environmental effect is North and South Korea, where North Korean children are around 8 to 10 centimeters shorter than their South Korean counterparts, and they're genetically identical. So.
And I have also a question regarding the bone age. So we are usually using the wrist X-ray. Till what age can we depend on this, and when should we introduce other bones to the bone age?
In fact, this is a question of Dr. Tadej. Why we are using left hand for the X-ray?
I mean, this is what they used. I'm sorry, you want to go on, Nando?
Well, I was only going to say the hand and wrist has a large number of bones. So when we do a hand X-ray, we're looking at 21 bones. I can't think of any other small part of the body you can X-ray conveniently and get that much information. So that's why we use the hand and wrist. And you can use it at any age. You can even use it in adults to confirm that growth has stopped in, for example, an 18-year-old who's hoping still to grow. So I don't, I think you can use the bone age really at any age, and you have to interpret it correctly. That's the rather important point, to actually have an accurate bone age.
I think we also use it because this is what the guy developed the book also. We're comparing to Ehrlich and Weil as well. But I think it's a very accessible part of the body, and it's very easy and it's not invasive. I think we have very good experience with that. And I always ask the parents to bring in the CD because I do not look at those reports. So please, whenever you send kids for evaluation, send them with their actual CD, not the report.
Okay, and the other question from Dr. Sharma regarding the same topic, which is what hand are we going to use, right or left, for the bone age?
It doesn't matter. There was a study of over 5,000 X-rays, right and left hand, from the same person. So they X-rayed both hands from the same person, and the bone age was essentially no different, whichever hand you X-rayed. Now, it may have been different 20 or 30 or 40 years ago when you'll be writing away frantically with your dominant hand in your lessons, but nowadays everyone's on keyboard, so perhaps the effect of handedness isn't so great anymore.
I agree with that. I mean, sometimes they do it in the other way and we just have to rotate it in the other way, so it's really doesn't matter. And again, when we look at bone age, we're not really 100% accurate anyway. So we still have to depend on other factors in addition to the bone age to determine or to assess growth as well.
Okay, so another question also about bone age. What is the best method for bone age assessment or estimation, from Dr. Satish?
I mean, I like Ehrlich and Weil, and I've been using it. So that's for me the best method. I think some other people recently have been using the Bone Expert, and I see that Dr. Nando has developed the Bone Expert, so I think he would be going for it as well. But I think at the end of the day, it's whatever you feel as a pediatric endocrinologist familiar with and reproducible information for you. Sometimes I have to go through 3-4 different plates to come up with a bone age, and sometimes, so again, it's whatever your pediatric endocrinologist is the best. But again, if you're trained in, you have to be trained to read them. Some of the reports we see are not that accurate. So don't rely on those some of reports that you guys get from radiology. I mean, I respect my radiology colleagues, but sometimes within the clinical picture, we see some of those bone reports don't match as well, so.
Okay.
It depends on your purpose, in that if you're, for example, wanting to predict final height, then there's no doubt that the Ehrlich and Weil method is the most accurate for future height prediction. And often that's what you are interested in when you're dealing with short and tall stature, for that matter. So I use GNP, but I can also read bone ages using the TW3 method, and that's actually more precise. So you can get a more exact number, like 11.26 years old or something, but it doesn't actually help you as much as you might like it to. So I think I would side with Dr. Hana that the GNP method, which is actually the method that Bone Expert uses as well, is probably the best and most practical method for clinical use.
Also, Dr. Hana, about can you get like normal IGF-1 and then you go and do the propagation test and then you find it not normal? How much?
So we're entering into the territory of growth hormone deficiency, or how do you define growth hormone deficiency? And again, it's not just the IGF-1 or the growth hormone stimulation test that tells me. If we test 100 kids who are growing well, 50 of them will fail the growth hormone. But that's not what we test, that's not we want. I mean, those kids who I think might likely have growth failure, I will send them for the growth hormone stimulation test. And those who fail have given me good evidence, better reason to start them on the growth hormone treatment. But doesn't change the fact that if you're very short or you're failing your growth chart and you qualify as your stature growth failure, we still have to consider growth hormone in spite of having normal IGF-1 and growth hormone stimulation tests.
Yeah, growth hormone tests are not really very good. I mean, Hannah knows just how much I despise them. But for example, you can have a normal growth hormone level in the blood, but actually it's bioinactive growth hormone. So what you're measuring isn't doing any good. You have to really look at the whole clinical picture, as Hannah said.
So I think the question.
I need to add one point about IGF-1. Below 5 years of age, really a low IGF-1 does not diagnose growth hormone deficiency. That's another point too. Below 5 years of age, you can still have normal growth hormone and low IGF-1.
Can you find it normal, and when you go and do the stimulation test, you find the abnormal stimulation test, like
again,
normal?
Because that comes back to the inaccuracy of the growth hormone stimulation test.
Okay.
Because again, you're taking snapshots of those random growth hormone levels. And if you were so unlucky to snap all these at different or the wrong times, you can still fail the growth hormone, although your IGF-1 looks okay. But again, as Dr. Nando said, your IGF-1 could be just very ineffective. So even your growth hormone could be, doesn't matter anyway, so.
And regarding the small for gestational age, like we should take this into account. Till what age? Or till the whole life? Like if one is small for gestational age, and then will they catch up later, or till when we should take this into consideration? Till which age?
So around 20% of short adults were SGA. So small for gestational age at birth. I don't want to be in trouble with Dr. Storab. So, you know, it's a significant burden actually on height. Height is important to people, as we can attest. I presume all of you here think height is important, otherwise you wouldn't be listening in or watching in. And in terms of what age do we have to start taking action if you're still small, having failed to catch up? Well, essentially you expect 80 to 85% of children who are born SGA to have normalized their height and weight by 2 years of age. And if you wait a little bit longer, by 4 years of age, 90 to 95% will have done so. So if you're going to catch up, you catch up early. If you're very, very small, let's say you're less than -3 standard deviation, then you're not likely to catch up ever without treatment. So in some situations, we will just intervene at an earlier stage. But typically, I would say between 2 and 4 years of age would be the point where you're declaring yourself, are you going to catch up? Or are you in need of help?
Sorry, I'm interrupting. We will have another session after Dr. Nando's presentation. This question on SGA and growth hormone, we have a lot of the question. Dr. Bushra, if you allow me, we'll discuss these questions after Dr. Nando's presentation.
There's only one question regarding vitamin D.
Yes.
How vitamin D is in growth hormone affecting? So this is the last one. Does vitamin D affect growth hormone, and what is the recommended dose?
I'm going to defer to Hannah as she's the vitamin D expert.
That's all.
I think the question is about what level of vitamin E that's really most important to us, and I think people have still the debate of is it 50 or 75, 20 or 30, it depends on your reference value. I would say for what diagnosis? I mean, for healthy growth, bone growth, you need to maintain the upper end of normal, you trust. And I mean, studies have shown that PTH above 30 with a vitamin D of 30 has suppressed your PTH level. But again, in kids who are nutritionally deficient, and again, each one, the dose depends on how much you maintain an absorption. So you really have to check to maintain the normal ranges. So I don't think I could specify, but again, depends on how low your stores are. I would be more aggressive. So I don't think I can really answer that questions.
I would like to thank Dr. Hannah because we're short of that. Thank you very much, Dr. Hannah, for excellent presentation and question and answer. And now I would like to request Dr. Nando to start his presentation. We'll have after that question and answer. There are a lot of questions regarding growth hormone, small gestational age, and other questions. And I would like to mention this for the viewers. We promise all these questions, those questions left, either in the WhatsApp or we will send the answer to your email, because we have a lot of questions. As far as possible, we'll try to discuss those questions left. We will either in the WhatsApp or through email, we'll try to answer. I mean, we'll request Dr. Hannah and Dr. Nando. Now I would like to request Dr. Nando to start this presentation. Thank you very much, Dr. Hannah. It was excellent presentation and discussion.
Good evening. Thank you all for giving up your evening. This is a very good occasion for us all to get together, although we can only do it virtually. I've certainly missed meeting friends and colleagues around Dubai over the last 6 months of torture. So on to my topic. So let me tell you about Ruby, who was born at 31 weeks gestation. A straightforward pregnancy to begin with, but then pregnancy-induced hypertension. Mom was very assiduous in avoiding anything that might imperil her pregnancy, but unfortunately, as you see, Ruby was born very small, 780 grams. She went into NICU, obviously, and needed oxygen and phototherapy. But essentially, the main problem for her was feeding and growing, and she was in NICU for quite a long time and left weighing 1.8 kilos. And you can see her growth chart here on the right. She had very slow growth. This is a growth chart up to about the age of 18 months. And unfortunately, as is often the case with these small babies, she had severe gastroesophageal reflux and probably in consequence of that developed oral aversion. So much so, in fact, that a G-tube was suggested. And sometimes we do have to go down that road. But her parents really didn't want that for her. They were concerned about the scar it would leave, and they felt that this was a temporary problem, so they were keen to leave her unscarred. As you see, not only was her growth in weight very poor, but her growth in length was pretty dismal. And if you look, you can see that the length is actually drifting away from normal even more. She had speech delay, but otherwise her development was satisfactory. Then if we look at a later age, the age of 4.5, her parents were concerned because she really wasn't growing well, and they requested a referral to endocrinology. And she had just started school, so the difference between her and children of similar age was even more obvious. And I often find this, that it's when starting school that we get a surge of referrals. So I'm expecting that in these next 2 or 3 months, at least from those who are actually attending in person. You can see her height and weight are well below the normal at 4.5. We did her bone age, and I have the wonderful Bone Expert system, which I've used for a long time. And her bone age was very exact, 3.13 years. She had a blood count showing mild iron deficiency, which is pretty ubiquitous in small children who eat with difficulty. Electrolytes, renal, liver function normal, celiac panel negative, and I endorse what Dr. Hannah said about the importance of checking for celiac disease in children who are not growing well. Thyroid function was also normal, although typically if you have hypothyroidism, you are relatively overweight, and obviously she was not. IGF-1 and IGF-BP3 were normal, and a chromosomal microarray was normal also. We prefer the microarray to the karyotype because it's much more informative, and often the karyotype quality that I've seen in Dubai is pretty poor. You know, if you'll see a report on 5 cells, for example, which is absolutely hopeless. You need a minimum 25 cells to confidently say that a karyotype is normal. So we diagnosed her as being short, secondary to being small for gestational age at birth. With that diagnosis, we don't need to proceed to a growth hormone test. And we put her on growth hormone initially as a therapeutic trial. This is how we use growth hormone. We start on the basis that we'll see how she responds, because it's possible that she has a growth hormone resistant condition. And her growth was excellent, so treatment continued. And if we look at the effect of growth hormone, you can see how she had a progressive rise in her height and actually attained a height between the 5th and 10th centiles by the time she was 7. If you look at her weight, she also just about got to the 5th percentile after 2 years of growth hormone treatment. So Ruby's parents were very pleased with her progress, although she remained very skinny with a terrible appetite, but her weight did improve. And her bone age delay had reduced to around 1 year. So the bone age delay does reduce in response to growth hormone treatment. In fact, this is what we're doing. We're using the money in the bank, the growth delay, to catch her up. So, that's where this residual catch-up growth comes from. Eventually, she'll get back to a channel and grow along that channel. But children will not uncommonly continue to catch up for the first 2 to 3 years after starting treatment. So if we think about the consequences of being born SGA, first of all, let's have some definitions. So if I just talk you through this, so obviously we have the normal range here in blue, and you can see here a child who is within the normal range, but their growth starts to tail off in late pregnancy. So this is a child who is IUGR, but appropriate for gestational age at birth, and this might be the child whose mother has preeclampsia. And if they are starting off smaller on the fetal growth curve, then they do fall off the bottom, so they end up with being SGA and IUGR. On the other hand, you might have a child like this one who is constitutionally small, such as, for example, the child with Down syndrome. They're born small and they are small throughout pregnancy. So technically speaking, they're SGA, but not IUGR. So these are important distinctions. Generally speaking, children who are born small, having previously been at a good height or length and weight earlier in pregnancy, they will catch up. So those children who are affected by, for example, preeclampsia, generally they catch up. If we think about the short-term consequences of SGA, then SGA is a cause of death. So there's a significantly higher mortality. Hypoglycemia is much more common. Obviously, if you've been starved in utero, you don't have the same energy reserves as you do if you've had a good pregnancy. When you have a low mass, you also have more difficulty thermoregulating. And there's usually associated with SGA, there's a degree of hypoxia from placental insufficiency, and that tends to lead to depression of the bone marrow, which manifests most often as thrombocytopenia, and usually, or not usually, but not uncommonly, children have thrombocytopenia when they're born SGA. Now, if we think about the longer term consequences, which is what I'm mainly going to focus on, obviously, then short stature is a very significant one. Now, that said, the majority of children will catch up. Children who are born small have a tendency to early puberty, and this can sometimes be a double whammy. You know, the child who's been tottering along on the bottom of the growth chart till 7 or 8 or 9, then they go into puberty and they end up with a disastrous final height. They have relative increased fat mass when they're older, and also associated with that increased blood pressure and dyslipidemia. And these are all insulin effects. So children who are born small for gestational age have insulin resistance, and this predisposes you to obesity, cardiovascular disease, type 2 diabetes when you are older. And this was a phenomenon first described by Barker from Southampton in 1990, the Barker hypothesis. So children who are born small have this cardiovascular jeopardy to look forward to in later life. And I think sometimes we add to that risk when they're very small by plying them with vast amounts of supplemented carbohydrate, force feeding them DuoCal practically to try and make them grow. They commonly have impaired neurodevelopment, and for example, attention deficit disorder and sensory disorders are much more common in children born SGA. They've also missed out on critical bone nutrients, and so low bone mineral density. And one benefit of the Bone Expert system that I use for measuring bone age is it gives me a measurement of bone density as well. And sometimes, you see a former premature baby, even though they're now 11 or 12, and it's shocking how low their bone density is, which we wouldn't have thought to measure on clinical grounds, but we see it because we get it as part of the bone age. In males, you have impaired gonadal function, so there's this unhappy quartet of low birth weight, hypospadias, undescended testes, and a risk of testicular cancer. And this is well described in SGA individuals. And kidney function is also commonly impaired. So in the younger children, they may have very low muscle mass, so they're not making much creatinine, so you don't see it so much. But actually, relative to their muscle mass, the renal function is poor. So catch-up growth. Now, in fact, the great majority of children who are born small for gestational age do catch up, and they don't need growth hormone or anything like it. And so if we look here at the child in the dark blue solid line, you can see that they're in this group, the 80 to 85% who catch up in the first 2 years of life. In fact, it's not uncommon for these children to overtake the normal and end up in the upper part of the range. Whereas this child in the dotted line, this is the child who has failed to catch up. Now, actually, some of these children do catch up if you wait long enough. But by the age of 4, the chance of them catching up is very small. And on the other hand, the chance of them doing well with growth hormone is very high. So there comes a point when you have to make a judgment, you know, how long do you wait for them to catch up? But I mean, so many parents have said to me, oh, we thought he would catch up, doctor. But actually, you know, the likelihood of catch up gets less and less and less once you're over the age of 2. So if you're short by age 4, certainly you need to have some help with your growth, and quite likely by age 2. And if you're very short at age 2, you're clearly not going to catch up by age 4. So mechanisms of growth failure, well, there's lots of things that play a part in this. It's a combination of genes and environment.
Excuse me, Dr. Nandu, 5 minutes, please. We are running out of time.
I'm sure I haven't been speaking for half an hour. But anyway, anyway, infants born SGA have increased concentrations of growth hormone, and often low levels of IGF-1 and BP3 are key markers at birth. So at birth, these children are somewhat growth hormone resistant. But later on, the axis appears to normalize somewhat, and they have normal responses to growth hormone stimulation for the most part. But there are normal, unusually normal levels of IGF-1 and BP3, but actually a subset has high IGF-1 levels, and that's particularly seen in certain variants such as Russell-Silver syndrome. And the mechanism of growth failure basically is multifactorial. In terms of genes, well, or genetic causes, so Russell-Silver syndrome, which I just mentioned, Temple syndrome, or uniparental disomy 14 is increasingly recognized. IGF-1 and IGF-1 receptor mutations, something called the acid labile subunit. If that's deficient, you can't carry the IGF-1 around your body very efficiently. You normally have undetectable IGF-1. And there are certain genes involved in insulin resistance and obesity. Also the ACE2 genes, which have been all the rage with COVID, and growth hormone receptor abnormalities, and that causes Laron dwarfism, and so severe growth hormone resistance. Those children won't grow with growth hormone. Onto the treatment, we use growth hormone to accelerate growth, to normalize height, and you know, it actually, even if it made little difference to your final height, it's still important to optimize growth in childhood, because this is when the child is living. This is the life they're experiencing now. This is when the bullying is happening. But in fact, if you treat children with SGA with growth hormone, you typically add 9 to 11 centimeters in final height. So it's a really worthwhile treatment and a very significant height benefit. These are the recommendations from the international societies regarding SGA. So if you're short, which is inconveniently defined as height less than minus 2.5 standard deviations and not catching up, then you should consider growth hormone treatment, and you can use a variable range. Europeans, like me, tend to veer towards the lower end of the dose range. The Americans tend to favor higher doses, and certainly higher doses should be used in children who are very small. That makes sense. And this is reflected in the different licensing for the US and the EU. So one of the things I mentioned was, you know, we wait for success. We define success. Now, in the UK, we define success as a greater than 50% increase in height velocity in 6 months. You could also define it as here, as an increase of more than 0.5 standard deviations in height in the first year of treatment. And you normally continue, if you are successful, if the treatment is working, you would continue the growth hormone therapy until the end of growth. So traditionally, when you're growing less than 2 centimeters a year, we would stop. Now, if you stop growth hormone in a child who has grown well with SGA, you actually get the reverse phenomenon of catch down. You grow even more slowly than you did before, so you end up no better off. So unfortunately, it is a commitment. If you're going to treat children with SGA, with growth hormone, you need to tell the families, you're in this for the long haul, you've got to carry this on till the end of growth, otherwise it will all be a waste of time. But there are children who don't respond. It's around about 8% of children actually don't respond, and there are a number of factors. The elephant in the room, of course, is always adherence. Are they actually taking it? Are we using a big enough dose? And we may need to consider the dose because there are some semi-growth hormone resistant states, such as children with IGF-1 receptor mutations. And for that reason, we want to consider other important diagnoses which could be contributing to the lack of growth. And we have to consider whether to stop treatment, and often it's a negotiation with the families. If we look at the overall effect of growth hormone, here you see children before and after treatment with growth hormone in the open circles before and in the closed circles after treatment. And you can see that whereas before treatment, the children were all below normal, with treatment, they reach a height within the normal range. Indeed, some of them well above the 90th percentile, which is an extremely good response. Neurodevelopment is actually aided by growth hormone. If you use growth hormone in young children, so children generally speaking under the age of 2 to 4 years of age, then actually you can demonstrate improvements in IQ of about 6 to 8 points. So this is not insignificant. It is a bit controversial. Some people don't believe that data. But I think I've seen that. You know, I've had parents report to me that their child's intelligence has benefited from growth hormone treatment, that they've seen that spurt in intellectual development as well as growth. And it certainly improves quality of life. So children who are bigger, they're physically more able, they can run and keep up with their classmates in the playground. So actually it's a positive for their child's quality of life, even though it's a daily injection. Although, as Dr. Sora pointed out, we are at the dawn of a new age of weekly growth hormone. In fact, we're expecting 3 weekly growth hormone therapies next year. Bone mineral density, I already mentioned how often the bone mineral density is very poor in these children born SGA, and actually there's good studies showing that bone mineral density improves with growth hormone treatment. And although it declines when you eventually stop treatment, it's still good to improve the bone density while you can. Bone density continues to improve until your mid to late 20s. In terms of monitoring of efficacy, we obviously are looking at height and weight, but we also monitor blood pressure because of this risk of hypertension in this group, and the Tanner stage, looking for that early puberty. And if necessary, we sometimes have to intervene with treatment for early puberty. And we monitor certain labs every year just to make sure that all is well. And I also do the bone age X-ray every 6 to 12 months. For those of you worried about irradiating children with bone age X-rays, the X-ray content is about the equivalent to half a banana or 1 minute of airplane flight, so it's not too hazardous to health. So eventually we get to the end of treatment. You know, we've raised the height of our formerly short child, and they're now at final height, so we're going to stop treatment. What happens to them? And actually the evidence is that they benefited from the growth hormone. So they had an increase in muscle mass, which does decline after they stop, and they have a reduction in their muscle mass once they stop treatment. But 5 years on, there's actually no difference in blood pressure or insulin sensitivity or other important parameters. So just to the summary, the key characteristic of SGA is birth weight and or length below -2 standard deviations. So that's at birth. The great majority of these children will catch up, and we don't have to worry about them. At least not in terms of their height. But in addition to the risk of short stature, there are other effects of SGA, which we obviously do have to attend to. And with growth hormone therapy, what we want to do is to accelerate growth to get that height into the normal range and achieve a normal adult height for the child. And with growth hormone therapy, if you're one of those responders, provided you're not one of that 8% who don't respond, you're going to get a normal height. Whereas without treatment, only a minority have any chance of achieving a normal height. And there we define the response to growth hormone treatment as a greater than 0.5 standard deviation improvement in height after the first year. Studies of growth hormone treatment in short children have shown that the treatment is well tolerated. Adverse effects are actually very rare. For example, there were theoretical concerns about whether it would cause diabetes or hyperlipidemia. This does not seem to be a problem, despite the fact these children are insulin resistant. You do need to undertake an appropriate workup for short stature as a prelude to considering treatment, and including considering genetic testing, although we all know how difficult that is to accomplish here in UAE. And it's very important to continue to follow up children on growth hormone treatment. This isn't a fire and forget treatment. They do need maintenance. For example, scoliosis is more common with growth hormone therapy because anything that improves growth increases the risk of scoliosis. If the child becomes overweight, they're at increased risk of slipped femoral capital epiphysis. Long-term studies, though, have suggested that continuous growth hormone treatment until final adult height improves height, has positive effects on metabolism, body composition, and quality of life. So with that, I'll leave you with some key references. And thank you for your attention, ladies and gentlemen.
Thank you very much, Dr. Nandu. Really, I'm grateful you finished in time or rather before that. One question is that Dr. Kalpana also has asked one question. Dr. Kalpana has asked which conditions show the most promising result in growth hormone therapy, and what is the cost of therapy and any serious side effect. And one more question, you said in catch-up is in 2 years, up to 2 years. Is there any clue to catch these children in early months of their life so that, we can help them? First, to answer Dr. Kalpana's question, then this, and Dr. Bushra will ask regarding the promising treatments, cost and the side effects.
So growth hormone is very costly therapy, unfortunately. I don't know that there's any, how do you value height? How do you, society has to make a judgment. Is it worth paying to make short children taller when you could use that money, for example, to treat patients needing renal transplants or other health problems? That's a judgment for society as a whole, I think. But it is costly treatment. In UAE, it's difficult to assess the cost because there are widely varying costs of growth hormone, but also the dose increases with your age and weight. So, because it's weight-related treatment usually. So the older you are, the more costly it is. Particularly if you have a growth hormone resistant state like chronic kidney disease or Turner syndrome, where we have to use high doses. So it's a challenge. The whole cost issue is difficult. And I apologize for that. What I really wish more than anything is that we'd had a Banting and Best in the growth hormone field who had sold the patent for $1, and that we could have cheap growth hormone, because actually there are many more children who could benefit from growth hormone than currently are able to get it. And that's a shame. It's not an expensive therapy to make. The technology was perfected in the 1980s. This is well past the date when we could have had cheap growth hormone if the companies were willing. But, they'll charge what the market will bear. And at the moment, the market is willing to pay these high prices. Now, in terms of how can we pick up the child who is going to catch up in the first, early on, before 2 years of age? Well, the answer is because they show signs of catch up even then. So the child who was, let's say, minus 3.6 standard deviations at term corrected, you see them at 6 months and they're up to -2.8. They're already catching up. So they're visibly catching up in this time frame. This is typically seen in the children whose mothers had placental insufficiency. These are the ones who are most likely to catch up. Think of them in a sense as starving refugees. They've now got access to food and they will grow when they have that access to food. So, you can see it earlier on, just as you can predict that the child who is very short, even though they're not 2 yet, you can see that they're not going to grow unless you do something, so I've got a very short child at the moment, -5.6 standard deviations. That's 1 in 250 million. That's the centile. That child is never, ever going to catch up without growth hormone.
Thank you very much. Over to Dr. Bushra. Dr. Bushra, please.
Yeah, thank you very much, Dr. Nandu. Very nice presentation. There are 2 questions also from Dr. Kalpana, partly were answered, but the most serious side effect of the growth hormone, and what are the criteria to stop it?
Okay, so side effects, actually growth hormone is remarkably safe treatment. And if you're using what we would call physiological doses, so the typical low dose growth hormone, 0.025 to 0.035 milligrams per kilogram per day, then that's physiological. You're very unlikely to see side effects. About 1 in 1,000 will get benign intracranial hypertension. So that manifests obviously with severe headaches, blurring of vision, and unfortunately in those children you have to stop treatment. You can restart at a lower dose after an interval of at least 3 months, but there's, in my experience, nearly all of those children relapse with recurrent headaches and have to stop treatment, and that's a real blow if that happens. It is rare, but actually it also happens with amoxicillin. It's just we don't hear about it. So it's just one of those things. If you're using high dose growth hormone treatment, then you're much more at risk of this side effect. So then we're talking about around 1% of children getting idiopathic or benign intracranial hypertension. The etiology isn't known. Interestingly, it also causes increased intraocular pressure. So your ophthalmologist can detect this actually. So sometimes where we have particular anxieties, we will get the intraocular pressure measured before starting treatment, because we can see the rise in the intraocular pressure quite easily and quickly before you get any other symptoms.
Okay, there's also a question from Dr. Muhammad Ashraf. Do you routinely order genetic tests prior to starting treatment, and what genetic test is done? Is it targeted study?
So basically there are a number of levels of tests. So there's the karyotype, which I would say is obsolete now, and it needs to be done well. You need to be looking at least 20 to 25 cells to have a reliable karyotype. Otherwise, you will miss important mosaicism. So that's a very important feature. And actually, I've seen karyotypes reported on 4 cells, which is shocking to me. So the microarray has really superseded the karyotype. It's much more informative, much more detailed. There's a whole bunch of conditions that you can diagnose on microarray that you will miss if you, for example, rush into doing whole exome sequencing. So I think a microarray is a good starting point. If the child has specific dysmorphic features, I mean, a classic one with SGA is microcephaly, so you could be talking about osteodysplastic primordial dwarfism, then you would go for a targeted gene panel. There's actually, I have a gene panel of about 390 genes that we look at to see if we can identify causes of short stature. So the first port of call, microarray, second port of call, targeted gene panel. If it's looking more complicated, we'll do whole exome sequencing instead, in which case ideally we'll also take blood from parents to help us identify any pathogenic mutations. But as all of you know, it's almost impossible to get coverage for these tests in UAE, so the parents have to have deep pockets to get a whole exome. And we can even do whole genome sequencing as well, actually. So it's ironic, actually. I had an offer in the mail, as in my email, for whole genome sequencing, $399. So it's amazing what you can get done on a private basis when you see what the labs will charge you for having it done commercially via healthcare.
Okay, there's a question from Dr. Rafia. What about calories intake to increase growth rate in small gestational age children?
So this is an interesting dilemma. Because if we ply these children with large amounts of carbohydrate, which is the usual strategy to augment calories, then there is a significant risk that we're adding to their insulin resistance and jeopardizing their future health in terms of obesity, early puberty, premature cardiovascular disease, and hypertension, type 2 diabetes. But obviously we don't want to starve the poor child. I think the key thing is to ensure they're having enough calories and, as far as possible, not to go crazy with carbs. Maybe we need to go keto on these. No, I'm joking. We won't go keto on these children, but
in this regard, with your permission, Dr. Busha, actually recently in the Middle East, they did a study use of cyproheptadine on increasing the height, and they found good results. What is your opinion on that?
Yeah, I use cyproheptadine a lot, actually. I didn't mention it earlier. We used it in Ruby, in fact. So cyproheptadine has been shown in 2 independent studies published in 2018 to improve height. Whether it's doing this by increasing oral intake or whether it's doing this by some direct effect on growth is not clear. The growth promoting effects were actually first recognized in the 1960s in the first publication in JAMA about cyproheptadine. So yes, I use cyproheptadine. I like it. It's very safe. It's available over the counter in many parts of the Middle East. In Lebanon, I know it's available as Cypro BC. You can buy it in the chemist. So it's very safe. It does cause drowsiness in some children. So I usually start with a dose at dinner time so that if the child falls asleep, it's not inconvenient. So it's a bit more problematic if they fall asleep at school. It's also quite good for motion sickness as well. So dose them up on the airplane, have them sleep the whole flight. So cyproheptadine, good treatment, and actually works even in severe growth failure conditions like Laron dwarfism, which was the paper you referred to, I think, from Iran. And also there was a paper in Russell Silver showing that the children grow better in terms of linear growth.
Okay, now another question. What about the protein intake to encourage the growth? Not necessarily the calories.
Yes,
I mean, the diet in general. Now, Dr. Rafia has sent another question. Yeah.
Okay, so
also Dr. Rafia.
It's about balance. So I think there is a limit to what you can get down these children's necks. Yes, if at all possible, I would say to try and avoid severe carb loading in these children. There at least there's substantial evidence that may not be a good thing in the longer run. So, for example, children who are born large for gestational age, which I realize is the opposite of what we're talking about. They already have this large amount of cargo on board. They are set up for a life of obesity. So it's a problem that is difficult to manage because what we have before us is the child who is small now. What do we do now? So I think optimize calories. That's sensible. Optimize intake of healthy micro and macronutrients. That's sensible. But about trying not to overload them with one particular macronutrient more than another. One thing I'm very fond of using actually in these very small children is zinc. So zinc is very effective at improving growth in small children. And it's commonly deficient. I mentioned they're iron deficient very commonly. They're also deficient in these other ions. So zinc is a critical growth micronutrient.
Dr. Najwa has asked, at what age we have to be worried about height and send to the pediatric endocrinologist?
In general,
questions, please rapid answers. Time is very short.
Okay. So in general, up to the age of 2, growth is primarily driven by nutrition. After the age of, let's say, 2 to 3 years of age, it's primarily driven by growth hormone and then later on by puberty and growth hormone. So I think it depends on the age. I'd say if the child is older than 2 to 3 years of age, probably you should refer to a pediatric endocrinologist. It's less likely, as Dr. Hannah said, to be endocrine at a young age, more likely to be nutritional or some other underlying ill health. But we do see endocrine problems in that younger group, so don't be deterred. But if they're small, over 2 to 3 years of age, that's the group. And in terms of who to refer, I would say if you're short for parents or you're growing slowly, that's the easiest way to think of it. Those are the children who we need to see.
Dr. Kalpana, if cyproheptadine is working, so does it mean increasing food will do the trick?
Yes, well, yes, it's true. So obese children are typically tall because they're driving growth independently of growth hormone. In fact, if you measure their IGF-1 and growth hormone secretion, they're low because the body's physiological homeostatic mechanisms are actually pushing growth hormone down. You don't need that. You've got all this food driving your growth. So yes, so food on its own is a driver to growth, but of course it doesn't make you taller at the end of the day. If you look at that obese 9-year-old who's 83 kilos, they also have a bone age of 12. So they finish growing sooner. They don't normally end up any taller than they would have been.
Okay. Dr. Kalpana, also not related, but growth in Prader-Willi. What about the growth in Prader-Willi?
So we do use growth hormone in Prader-Willi syndrome. It is a very good treatment, but actually the main benefits in Prader-Willi come in terms of muscle strength and cognitive benefits. And so as soon as we make the diagnosis, we like to treat children with Prader-Willi. I mean, ideally, even from 3 months of age, we would treat because these children are so hypotonic. And the adverse body composition is established very early on, even before they become fat, because they're not moving their muscles. So their muscles are paltry and useless. So growth hormone gets them moving, gets their muscles working, helps their motor development. And I already mentioned that growth hormone is good for cognitive development. So our primary goal in growth hormone Prader-Willi is not to drive growth, although that is a good thing because they are growth hormone deficient, but to make them smarter and stronger.
Okay, Dr. Amir, what about pituitary gland medication for height increase? Pituitary gland medications for height increase.
I guess, so growth hormone is the growth factor from the pituitary that makes you grow. Obviously, you do need to have thyroid or TSH from the pituitary as well to drive the thyroid. There are some data on growth hormone releasing peptides, and some people think they may be beneficial in SGA and non-growth hormone deficient short stature, but they've been really rather disappointing. So these growth hormone releasing peptides were discovered around 25 years ago, and people thought this would be it. We don't need to use growth hormone injections anymore. But in fact, although they do cause growth hormone release, they don't seem to be growth hormone growth-related growth hormone release. So for example, a starving child has high growth hormone levels, but they're not growing. So there's a disconnect between nutritional drivers of growth hormone release and growth itself.
Sorry, I'm interrupting. We can have one or two more questions because if we go like this, there are so many questions till morning. We will go. We have already half an hour. I've been exceeded our time. Dr. Bushra, one or two more questions and final note up because we have only 2 minutes.
Okay, this is from Dr. Kalpana. How often is endogenous growth hormone excess diagnosed in children?
Well, to coin a phrase, hen's teeth and rocking horse manure. If I've seen 2 children in my practicing lifetime in over 30 years, so it's very, very rare. In contrast to acromegaly, which is relatively common in adults, but often acromegaly does have its roots in childhood, actually, when you look at old photos. But the standout is, as in the picture that Dr. Sohrab showed, you know, that you're unusually tall at a young age, and it's really very distinctive, you know. So obviously Robert Pershing Wadlow was over 6 feet tall at the age of 9. So you know, he was obviously growth hormone excess at a young age.
So this is again Dr. Amir. In fact, he is correcting me. Maybe I missed it. He's saying it's a growth hormone, pituitary gland meditations, not medications. Pituitary gland meditations. Anything for any role in growth?
So
Meditation.
this is the last question.
Okay.
For meditation.
Yeah,
Well,
meditation.
I'm sure meditation is good for you, but I don't. I mean, I do advocate yoga actually for growth, because actually posture and stretching is very important for growth. But meditation, I don't know anything about that. He probably knows more about that, or she, than I do. So please fill me in. But it's
So
not.
thank you very much. I'm very sorry because our time is over. Thank you very much, Dr.
Dr. Saurabh.
Excellent presentation, discussion. Thank you very much, Dr. Hannah, Dr. Bushra. I would like to request all viewers, there is a survey. You please fill that one. I would like to thank Novo Nordisk, Dr. Rakesh Nair, Dr. Magded, and Dr. Sharif for hosting and organizing this webinar. There are a lot of questions. I think if we go till morning, we won't be able to finish. I promise in WhatsApp and email to answer all these questions. Now, I would like to thank all viewers and over to Dr. Magdi. Thank you very much.
Thank you very much on behalf of Novo Nordisk. I just wanted to make a point where Dr. Nandu just mentioned about the cost. What is happening is also we will be shortly coming out with a program to support patients who cannot afford growth hormone, which is a patient support program, which would be approved by the Ministry of Health and the Dubai Health Authority and the Department of Health in Abu Dhabi. So just to add on to Dr. Nandu saying that the cost is a major concern. So we understand that, and this whole program is designed to address this unmet needs.
Thank you very much. Thank you. So with this, really, I would like to thank Novo Nordisk for this hosting this excellent webinar. Our speaker, Dr. Nando, Dr. Hannah, Dr. Bushra also. I would like to thank all viewers for joining us. I'm sure a lot of questions are left. We will try to have another session, the second part, to continue this. Once again, I would like to thank everybody. Over to Dr. Magdi, Dr. Nair. Please.
Most welcome, Dr. Saurabh. Thank you so much for having us in your.
Dr. Sharif Hamdi, you remind me of Baligh Hamdi, the great composer of the Egypt in 60s. Please.
I'm glad that this guy is a big shot in Egypt, so I'm glad that I remind you of him. I'd like to thank you all for all of the attendees for coming today, and it's been an honor for Novo Nordisk to sponsor this club meeting. Great group. Dr. Sohrab had the big effort to make this successful as possible. Thank you, Dr. Sohrab, for having us. Thank you, Dr. Nando, and all the speakers, and Dr. Hana, and everyone. I think now we can enjoy the rest of the evening and enjoy the weekend, inshallah.
Thank you. And don't forget to fill the survey. Thank you very much. Thank you very much.
Okay, thank you.
Thank you, Dr. Nando. Excellent presentation. Really, you finished in time also. We are very grateful to you. Thank you.
Thank you.
We have another session also. So it was very good. Really, everybody enjoyed the session. Myself, really, I learned many things. Thank you very much.
Oh, that's good. How many did we have in the end? I know you promised us 2,000, but
It was 2,000, but one zero was missing.
I see. Oh well.
No, really, it was very good. All those who were interested, they joined. We learned a lot. We learned a lot. Really, it was very good.
Okay.
Thank you very much.
Good evening, everyone. For those who are still inside, just ensure that when you leave the webinar, the survey page will pop up on your window. Ensure that you answer that and give us your feedback. Thank you so much. And we're going to end the webinar now. Thank you and have a great evening.
Thank you.
Thank you.